Hi, everyone. My name is Reese Garcia, and I'm the Research Advocacy Manager for Fight Colorectal Cancer. Thank you all for joining the webinar this morning or afternoon if you're on the East Coast. Today, Dr. Caitlin Murphy will be discussing colorectal cancer screening trends in the United States. As always, thank you to the following webinar sponsor, No Shave November, for making our webinar series possible. A few housekeeping items before we begin. You can ask questions in the panel on the right side of your screen or use the chat function. The webinar will be housed on the FightCRC website at fightcrc.org afterwards. And if you have a Twitter, please tweet along and follow FightCRC on Twitter using the hashtag CRCwebinar. FightCRC offers a wide variety of resources for those touched by colorectal cancer, and you can find all of these on our website as well to download the latest resources. The information and services provided today by Fight Colorectal Cancer are for general informational purposes only. The information and services are not intended to be substitutes for professional medical advice, diagnoses, or treatment. If you're ill or suspect that you're ill, see a doctor immediately. And in an emergency, you can call 911 or go to the nearest emergency room. FightCRC never recommends or endorses any specific physicians, products, or treatments for any condition. And with that, I would like to introduce today's presenter. Dr. Caitlin Murphy, who is also on FightCRC's Medical Advisory Board, is an assistant professor in the Department of Population and Data Sciences. As an epidemiologist with expertise in GI cancers, Dr. Murphy's research focuses on understanding the causes and outcomes of colorectal cancer. She has experience conducting population-based research across the cancer care continuum, including etiology and risk assessment, screening, patterns of care delivery, and cancer survivorship. Prior to joining the faculty at UT Southwestern, Dr. Murphy was a fellow in the Digestive Disease Epidemiology Training Program at the University of North Carolina at Chapel Hill. She received her MPH in Health Promotion and Behavioral Sciences from the University of Texas School of Public Health and her PhD in Epidemiology from the University of North Carolina at Chapel Hill. And with that, I would like to welcome Dr. Murphy to discuss CRC screening trends with us today. Dr. Murphy, I will hand it over to you.
Can you guys see my screen okay?
Yes.
Okay, perfect. Well, good morning from Dallas and good afternoon to those of you on the East Coast. I'm looking forward to talking to you today about an overview of colorectal cancer screening trends in the United States. So before I get started, I want to walk you through my agenda for today. My goal is to provide some information and data that will help us address the questions that I've listed here on this slide. I'll start by talking a little bit about colorectal cancer incidence and mortality rates, or the number of new cases diagnosed and the number of colorectal cancer deaths each year. We'll then talk about some of the different types of screening tests available for colorectal cancer, as well as the guideline recommendations for screening in persons at average risk. Towards the end, I'll spend the bulk of my time describing the proportion of people up to date with screening in the US, including differences in screening uptake by factors like race, ethnicity, and age. And then I'll wrap up by talking about the impact of these differences or disparities in screening on colorectal cancer incidence and mortality. So let's jump in and get started by talking about the overall trends in colorectal cancer incidence and mortality rates. I often get asked why I choose to study colorectal cancer of all the cancers out there, but for me, the answer is quite simple. Unlike most cancers in the United States, overall, we've seen a steady decline in colorectal cancer incidence and mortality rates over the last 30 years or so. Here in this figure, you can see that both the number of new cases, or the incidence rates, as well as the number of colorectal cancer deaths, or mortality rates, have declined in the US since the early 1990s. And again, this is across all age groups combined. When we look at incidence rates, or again, the number of new cases diagnosed through a slightly different lens, you can see that those overall declines in incidence I showed you on the previous slide have really been driven by dramatic declines in older adults or those over the age of 50. This figure shows you incidence rates in two different time periods. Here, age is along the x-axis, and each line represents a different time period. You can see big declines in incidence from the late 1980s, shown in this gray color, to the most recent time period through 2016, shown in blue. You can also see that there's this sharp break in the curves, or that the declines in incidence have been limited to people over the age of 50. This slide again uses those same data, but again, we're just looking at incidence rates through a slightly different lens. Here I'm showing you incidence rates in 3 different age groups: older than age 65 in blue, between the ages of 50 and 64 in this orangey peach color, and then below the age of 50 in the gray color. The declines in incidence over time have been quite dramatic for those over the age of 65, and you can still see that there are some declines in this 50 to 64-year-old age group, although they do appear a little bit flat on this particular figure because of the large scale of the y-axis. Here's that same exact figure, except this time I'm showing you mortality rates. Again, we can see these huge declines in mortality rates for people over the age of 65 who are shown in this blue color, and then somewhat to a lesser extent for people between the ages of 50 and 64, although certainly still declining in this age group over time, which is again shown in that orangey peach color. For people like me who study colorectal cancer screening, these declines in incidence and mortality in older adults are especially exciting because they provide us some evidence that screening actually works. So in the next several slides, I'm going to talk more about colorectal cancer screening, the types of screening tests available, and for what groups screening is recommended. When we think about colorectal cancer screening, we typically divide the types of screening tests available into 2 different categories: direct visualization test and stool-based tests. I'm going to talk more in depth about all of these test types over the next few slides, but just wanted to give you a high-level overview here. Direct visualization tests are exactly what they imply. They allow the physician or person performing the test to examine the entire colorectum. Because of that, these tests are often more invasive, but they do also allow the physician to identify and remove precancerous lesions, often called polyps or adenomas. Colonoscopy, sigmoidoscopy, and CT colonography are all direct visualization tests. And again, I'm going to talk more about these test types over the next few slides. The other category of tests is a stool-based tests, which again are also exactly what their name implies. They use a small sample of stool to screen for colorectal cancer. They're easy and non-invasive. Oftentimes you can do them in the convenience of your own home. They screen specifically for hidden blood in stool or biomarkers in stool. So if the test comes back positive, you may need to get another test, oftentimes one of those belonging to this direct visualization category. Stool-based tests include FOBTs, FITs, and FIT DNAs. And again, I'm going to talk more in detail about these specific test types over the next few slides. So first up is colonoscopy, which I'm sure many, if not all of you, are familiar with. This is a more invasive screening test and requires conscious sedation or some kind of anesthesia to relax you or put you to sleep. The doctor uses a long, flexible tube with a light at the end, which is called a colonoscope, and that allows him or her to see the entire colorectum from the inside. In advance of the test, you must clean or prep your colon, often with a solution that we call bowel prep. This is probably the most difficult part of a colonoscopy for a lot of people, but it's important to completely clean out the colon so that the doctor can identify and remove precancerous lesions, or again, things we call polyps and adenomas. If a colonoscopy is normal or there are no precancerous lesions, it should be repeated every 10 years. Next is a sigmoidoscopy, which I like to think of as sort of a mini colonoscopy. And that's because it only examines the lower part of the colon and rectum, which you can see here in the graphic at the right, and not the entire colon. Because of that, this test is often considered less invasive. It requires less complex preparation, or again, bowel prep, and less sedation. Like a colonoscopy, this test can identify and remove precancerous lesions, but a doctor may require a follow-up colonoscopy to make sure that there aren't any other lesions in different parts of the colon, like up here, that the sigmoidoscopy didn't reach. If normal, this test should be repeated every 5 years. The last direct visualization test is a CT colonography, or a virtual colonoscopy. We call this test virtual because a CT scan provides 2D and 3D images of the colorectum, and I've given you a couple of examples of what those images look like here on the right-hand side. This is a less invasive test than a colonoscopy, but you still have to clean or prep your colorectum in advance of the test. This is again so that we can clearly and cleanly see when there might be precancerous lesions. For example, you can see there's one right here in this image on the right-hand side of the screen. Positive tests, or those with lesions that occur about 40% of the time, must be followed by a colonoscopy so that those lesions can actually be removed. But if the test is normal, CT colonography should be repeated every 5 years. So in the next group of slides, I'm going to talk more now about stool-based tests. First, I'll talk together about fecal occult blood tests, or FOBTs, and fecal immunochemical tests, or FITs. These tests are both non-invasive and, as I mentioned a few slides ago, oftentimes can be done in the convenience of your own home, or in this case, your own bathroom. They look for small amounts of blood and stool that may be a sign of cancer. If the test is positive, which they are about 5% of the time, it must be followed by a colonoscopy to look for and diagnose cancers or those precursor lesions that may be causing the blood in your stool to appear. If normal, these tests must be completed every 1 to 2 years. Typically in the US, we recommend them every year, but in Europe and some other countries, they're recommended every 2 years. So next is a FIT DNA test, often called by its brand name Cologuard. You may have seen commercials for this test that often feature its logo, which I've included here on the right-hand side of the screen. Like FITs and FOBTs, these tests are non-invasive and look for small amounts of blood in the stool that may be a sign of cancer. But in addition to that, they also look for precancer or cancer biomarkers in stool, which is how we get the name FIT DNA. Positive tests, which occur about 15% of the time, must be followed by a colonoscopy, but if normal, these tests can be repeated every 3 years. So lastly, there's this colorectal cancer screening test that doesn't quite fit into the direct visualization or stool-based test categories, and that's a double contrast barium enema, or sometimes we simply refer to this as a barium enema. This test is less invasive than a colonoscopy because it takes x-rays of the colorectum from the outside. But in advance of the test, and as the name implies, you'll need an enema of barium, which is a silvery white metallic compound used to make the colon show up better on an x-ray. And I've included a few pictures here on this slide of what exactly that looks like. Because it is just an x-ray, you don't have to be sedated, but you still need to advance or do bowel prep before the test. Like many of the other tests that we've talked about, positive tests have to be followed up by a colonoscopy. If normal, a barium enema can be repeated every 5 to 10 years. I want to make a point to say that these tests are really not routinely available, but instead they may get used for patients who show up to a colonoscopy but maybe don't do a great job with the bowel prep, or for some reason they aren't tolerating the procedure well. So rather than forgoing a screening test altogether, these barium enemas can often be done on the same day instead. So now that we've gone through each of the screening test types in more detail, I want to talk next about what the guidelines recommend for screening in persons at average risk. By average risk, I mean people who have no family history of colorectal cancer, no genetic predisposition like Lynch syndrome, and no symptoms of colorectal cancer like rectal bleeding. So here and throughout the rest of the presentation, I'm really going to focus only on screening for persons at average risk. There are lots of different guideline recommending organizations out there, but typically each of them will make a recommendation for the age to start screening, the age to stop screening, the recommended tests, and then perhaps any additional considerations or caveats related to those recommendations. For example, the United States Preventive Service Task Force, or USPSTF, try saying that 10 times fast, recommends starting colorectal cancer screening at the age of 50 and stopping screening at the age of 75. They recommend almost all of the test types that we reviewed a few minutes ago, with the exception of barium enema. They make a point to say that all of the recommended tests are considered equally effective, or that no one test is better than the other. And in doing so, they really encourage physicians to offer patients a test that they are most likely to complete. Another guideline recommending organization is the Multi-Society Task Force, which is comprised of several gastroenterology-specific organizations. Like USPSTF, they recommend starting screening at the age of 50 and stopping at the age of 75. But they're a little bit different in that they split up their recommended tests into Tier 1 tests and Tier 2 tests. The Tier 1 tests, which they recommend over the Tier 2 tests, include FIT and colonoscopy. They do also recommend that Black persons start screening at the age of 45 instead of 50, really driven by the higher rates of colorectal cancer that we see in that particular group. I've also included recommendations from the American College of Physicians, which is sort of the governing body of all internal medicine physicians. Their recommendations are near identical to the USPSTF, but they also include barium enema on their list of recommended tests. And then finally, you can see here on the right, there are recommendations from the American Cancer Society. You'll notice that they recommend starting screening at the age of 45 instead of 50. This is a qualified recommendation, which I've marked here at the bottom of the table, meaning that there is no evidence from clinical trials suggesting that screening start at age 45, but we do know that incidence rates have started to increase in younger adults, and the risk may now be similar to what it was for 50-year-olds many years ago. The American Cancer Society recommends the same tests as the USPSTF, as well as to stop screening at the age of 75. So far we've talked about the different tests available for colorectal cancer screening and about the recommendations from various professional organizations for when to start screening and with what tests. I want to talk next about how we're doing in the United States, or how we can measure the success of colorectal screening and the number of people up to date with recommendations. There are two sources of data here in the United States that we use to track and measure colorectal cancer screening. The first is the Behavioral Risk Factor Surveillance System, or BRFIS, which is an annual telephone survey that collects information about health-related risk behaviors, chronic health conditions, and the use of preventive services like screening. The survey is implemented in all 50 states, Washington, D.C., and 3 U.S. territories, and it collects more than 40,000 responses each year. The second is the National Health Interview Survey, or NHIS. This is an in-person survey conducted in people's households about a broad range of health topics. The interviews are done in all 50 states and Washington, D.C., and about 30,000 adults and 9,000 children participate each year. So on the next several slides, I'll be using a combination of these data to describe the proportion of people up to date with colorectal cancer screening, or more specifically, those who meet the recommendations of the USPSTF at the time that they're participating in either of these surveys. So here you can see the proportion up to date with screening over time, again, meaning that people have recently completed any one of the recommended tests. Although the proportion up to date is not quite as high as we'd like it to be, you can see that it's increased over time from about 40% in the year 2000 to 65% in the year 2018. You can also see that increases in colonoscopy use have really driven that overall increase in screening. This orange dotted line here shows you those who have completed colonoscopy in the last 10 years. And this line really parallels the overall proportion who are up to date in that blue line at the top. In contrast, you can see that the use of FIT, or FOBT, has somewhat declined over time from about 20% in the year 2000 to about 10% in 2018. So all in all, we're doing okay. Colorectal cancer screening is increasing in the population, but there's still a lot of work to do. Colorectal cancer screening lags behind many other screening tests like mammography, as well as national goals for screening. There are a number of barriers to colorectal cancer screening, including the cost, time required, lack of awareness, fear or embarrassment, and access to these tests that may contribute to the slower progress we've made in getting everyone up to date. I know Fight CRC has several webinars planned over the next few months to really dig deep into these barriers and identify solutions for overcoming them. There are also important differences in screening up-to-dateness by factors such as age, sex, race, ethnicity, poverty and income, insurance type, education, and even geography. And I'm going to spend the next few slides talking in more detail about some of these differences. So as a reminder, on this slide and throughout, I'm using a combination of data from BRFIS and NHIS about the proportion of people who are up to date with screening or those who meet the recommendations of the USPSTF. Here I'm showing you differences in screening by age and over time. The blue color is ages 50 to 59, the gray color is age 60 to 69, and then this orange peachy color is 70 to 75. Not too surprisingly, the proportion up to date increases with age, where about 80% of people in their 70s are up to date compared to just about 50% of people in their 50s. This is pretty consistent over time, where we can still see these age-related differences in each of the 3 years I've illustrated here, 2014, 2016, and 2018. Screening also differs by sex. About 75% of women are up to date with screening compared to just about 2/3 of men. In this figure, I'm showing you differences in screening by race, ethnicity, and how these differences look over time. This orangey peach color is Hispanics, turquoise is Asians, dark blue is whites, and then the gray is blacks. I think the most notable thing to me in this figure is the much lower proportion of Hispanics who are up to date with screening compared to the other groups. About 45% of Hispanics up to date compared to almost 70% of whites. There really isn't much movement in any of these groups over time, and in the most recent year, 2016, which is shown here, you can still see that screening in Hispanics lags far behind the other groups. Here's a closer look at screening in Hispanics broken down by English and Spanish speakers. On the left-hand side of the screen, you can see that a higher proportion of English-speaking Hispanics are up to date compared to those who speak Spanish as their primary language. And then on the right-hand side here, I'm showing you the use of different screening tests among Hispanics, again, broken down by English speakers and then those who speak Spanish as their primary language. Like the overall trend in the population, you can see that most of them are up to date by completing a colonoscopy. But I do want to point out to you that a higher proportion of Spanish speakers complete FIT or FOBT compared to English-speaking Hispanic speakers, or English-speaking Hispanics rather, which may give us some clues about how to increase screening in this population. So next I'm showing you differences in screening by neighborhood poverty level, where blue indicates poor neighborhoods, gray is near poor, and then this pink color is not poor at all. People living in poor neighborhoods are least likely to be up to date with screening, about 40% compared to 65% in those no poverty neighborhoods. And you can see that this is true both in the year 2010 as well as the year 2018, although it does seem that these differences by poverty level have narrowed a little bit in 2018. There are also differences in screening by insurance type, and specifically screening is lower among those who are uninsured or who have Medicaid. Here I'm showing you the proportion up to date with a number of different insurance types, including employer-sponsored or commercial insurance, Medicaid, Medicare, military coverage like through the Veterans Health Administration, or then having no insurance. Again, you can see really striking disparities in screening up-to-dateness by insurance, particularly for those who have no insurance, where only 25% are up to date. Similarly, we also see differences in screening by educational attainment. This figure shows you the proportion up to date for 4 different categories of education: less than high school graduate, some college, and then college graduate. and then separately for men here and women over here on the right. We can see that screening uptake is much lower among those with less than a high school education compared to college graduates, and that's true for both men here and women again over here on the right. And then lastly, I want to highlight that there are even geographic differences in screening uptake. This map is of all 50 US states and shows you the proportion up to date in each state. And this ranges from 75.8% in Connecticut to 58.5% in New Mexico, which is almost a 20% difference. The states with the lowest proportion up to date are highlighted in red and orange, which you can see tend to cluster in the South and the Southeast, as well as some states up here in the Mountain West, like Idaho and Wyoming. So as I start to wrap up, I want to end by talking about what all of these differences or disparities in screening uptake really mean for the health of the population, and specifically how they might impact colorectal cancer incidence and mortality rates. For example, I just showed you geographic differences in screening uptake, where a lower proportion of people up to date tend to live in states in the South and Southeast. Here in this figure, you can see that mortality rates of colorectal cancer also tend to be higher in those particular states. The darkest colors in this map correspond to the states with the highest mortality rates, where we see some of the same ones that were implicated in the screening figure, like here in Mississippi and other states in the Southeast. But we also see states with high mortality rates in places like Appalachia or West Virginia area, where again, we know that there are differences in some of the education, insurance type factors in these communities that may contribute to disparities in screening and outcomes. We also talked earlier about differences in screening uptake by race ethnicity. For example, screening tends to be higher in white persons compared to Black persons. Sure enough, we can see differences in colorectal cancer incidence rates between these two groups. This figure shows you the number of new cases diagnosed, or again, incidence rates for white and Black persons over time since the early 1990s. And you can see that Blacks, who are shown in this gray line, have had persistently higher incidence rates of colorectal cancer compared to whites, who are shown in this blue line. What's more is that Black persons are also more frequently diagnosed with colorectal cancer at a later stage of disease, when survival is much, much lower. In this figure, I'm showing you the proportion of white and Black persons diagnosed with colorectal cancer at a local stage here in blue, regional in the peachy orange color, and then distant in gray. You can see that a higher proportion of Black persons are diagnosed with distant disease, about 25% compared to white persons. And then finally, continuing along that theme of Black-white disparities, we also see higher mortality rates among Black compared to white persons, and for every stage of disease. This figure shows you mortality rates of colorectal cancer over time for local, regional, and distant stage disease. This yellow line shows the mortality rate in Black persons and blue line in white persons. For each disease stage, you can see that Black persons have a higher mortality rates compared to whites, and this is particularly pronounced for distant stage disease, which I'm showing you here on the right. Beyond race and ethnicity, we also saw that colorectal cancer screening differs by education and poverty, where screening tends to be lowest among those with less than a high school education and among those living in high poverty neighborhoods. Those differences in screening translate to differences in incidence rates. This figure illustrates colorectal cancer incidence rates across 5 different categories of education: less than high school graduate, some college graduate, and then having a postgraduate degree. Quite strikingly, there's about a 40% difference in incidence rates between the lowest and highest educational attainment groups. And remember that we also see big differences in screening uptake between those groups. Similarly, we see higher incidence rates among those living in high poverty neighborhoods. This figure shows colorectal cancer incidence rates broken up into quintiles of neighborhood poverty, where the dark blue color corresponds to the lowest poverty level and pink to the highest poverty level. Here, there's about a 20% difference in incidence rates between persons living in high compared to low poverty neighborhoods. And again, you'll remember that there were also marked differences in screening uptake across poverty levels that we saw a few slides ago. So we've gone through a lot of data and figures today, and on this slide, I want to start to summarize some of the key points that we've talked about. Overall, or across all age groups combined, colorectal cancer incidence and mortality rates are decreasing in the population. Although there are probably a number of reasons why rates are declining, people like me who study colorectal cancer screening appreciate that these declining rates are evidence that screening actually works. Colorectal cancer screening is one of the only types of screening that can actually prevent cancer because it removes precancerous lesions, as well as reduce the risk of death from colorectal cancer by detecting it at an earlier, more treatable stage. There are many different tests recommended for screening in persons at average risk, and because these tests are regarded as equally effective, conventional wisdom would tell us that the best test is the one that gets done. Colorectal cancer screening has increased in the population over time. About 65% of eligible adults are now up to date with screening recommendations, but it still does lag behind many other cancer screening tests like breast or cervical cancer screening. There are also marked disparities in screening by age, sex, race, ethnicity, poverty and income, insurance type, education, and even geography. And oftentimes screening uptake is lowest in the underserved groups. These disparities in screening contribute to disparities in colorectal cancer incidence rates, stage at diagnosis, and mortality rates in those same underserved groups. Ultimately, on this last slide, I want to emphasize what we can accomplish when we increase the number of people up to date with screening, and equally so across the population. There have been a number of studies conducted that suggest when 80% of the population is up to date with screening, by the year 2030, we can reduce the number of colorectal cancer cases by almost 300,000 and avert 200,000 colorectal cancer deaths. Thanks very much for your time, and I'm looking forward to taking your questions during the Q&A session.
Wonderful. Thank you so much, Caitlin. I'm going to share my screen now. All right, and we've had some great questions coming in. I'm getting a little feedback. Does anyone else hear that? Okay, I'm going to try muting you really quickly. And okay, that solved it. So Caitlin, the first question we have is, with the latest guidelines from the American Cancer Society to start colorectal cancer screening at 45, why haven't other organizations followed suit? I'm seeing many patients under the age of 50 and 40 even that are diagnosed with CRC.
Are you still getting the feedback, Reese, when I talk?
Sounds good.
Okay, yeah, that's a great question, and I think one that challenges a lot of scientists, gastroenterologists, and epidemiologists like me. I mean, you're right in that incidence rates of colorectal cancer are increasing quite dramatically in people under the age of 50. And these are people who historically are not eligible for colorectal cancer screening based on their age. So in 2018, the American Cancer Society updated their recommendations for screening. And as you saw on my slide, now recommends that people start screening at the age of 45. I think the reason why other organizations have not adopted this recommendation yet, or may not in the future, is because there really is a lack of evidence from clinical trials suggesting that screenings start at the age of 45. Instead, the American Cancer Society made their recommendation based on modeling studies. And even though they do provide us a good estimate of will screening work and at what ages, they're still not based on any actual real world data. So I think time will tell if other organizations sort of adopt a similar approach and start to recommend screening at a lower age. I think the USPSTF is reconsidering their screening guidelines, although I don't have any firsthand knowledge of that. It's more a rumor. So I think time will tell what other organizations decide to do.
Perfect. Thank you for that. And just as a follow-up from the individual who asked the question, she works in Kentucky, Appalachia, and we're seeing quite a lot of 20 to 30-year-olds with rectal cancer in the past few years, many with HPV. Do we need to push the vaccines more in our younger population as well?
I think, yeah, those are two separate questions. Number one, certainly because of cervical cancer and other oral cancers and anal cancer prevention, we should definitely promote the vaccine in both men and women. The second question is more about colorectal cancer, where we don't have definitive evidence that HPV is associated with risk of colorectal cancer. But one thing that I think we can do to help the youngest people get diagnosed more quickly is to really encourage both them and physicians to recognize the signs of colorectal cancer. So for example, rectal bleeding is an important sign that often might get ignored or sort of overlooked in younger people because they think, oh, it's a hemorrhoid or it's something else. But I think one of our challenges and sort of important next steps is to really push upon people the importance of identifying these symptoms and getting them worked up quickly because rates of colorectal cancer are increasing in that younger population.
Great, thank you for that. And then we had a few questions come in specifically around COVID. So I'm going to combine some of these. Do you have current information related to the impact the pandemic has had on screening? And can you project how COVID-19 will affect screening rates and ultimately mortality?
I can say that we're working on it, and I can speak for my local experience. So here in Dallas, we do a lot of work with our safety net hospital system, which is funded by the county for people who don't have insurance or might be underinsured. And during COVID, we essentially stopped all colorectal cancer screening, including mailing FIT kits, doing diagnostic colonoscopies, or working people up for symptoms. So we started to sort of slowly restart some of those processes now that we've learned a little bit more about COVID and how it spreads. But I think there's going to be a huge backlog, not only just at my hospital, but at places around the country. And I think there are a lot of researchers who are dedicated to understanding how this will ultimately impact mortality rates, as well as late stage diagnosis and some of those other things. So I don't know the answer quite yet, but I know people are working on and will continue to study that as the pandemic moves on.
Great, and I think it's very relevant right now and a question at the top of all of our heads. This question asks, why do you think underserved groups are not getting screened? I know it's probably a combination of a lot of things, but what would you say the top few reasons are? Culture, lack of insurance, lack of doctors, not pushing them, avoiding all care?
I can speak to just a couple of the things that we hear from patients, again, at our safety net system here in Dallas, where I'd say the two biggest barriers are, number one, the cost or the time required. So oftentimes, if you're getting a colonoscopy, you need to take some time off of work. You need to find a person to drive you to the test because you'll have some kind of sedation that won't allow you to drive. And there is a copay associated with that, which can range, over a sort of broad range of dollar values. And the second thing that we hear a lot is, if I had cancer, I would know. And so I think a lot of patients are reluctant to complete cancer screening because there's this sort of heuristic belief that, like I said, if I had cancer, I would know. Sometimes these patients might complete a FIT, so one of those stool-based tests that you do every year, but when the test is negative, it almost sort of reinforces the belief that, well, if I had cancer, I would know. So I think we have a lot of work to do in terms of overcoming some of the logistical barriers like cost, but then some of the beliefs about, the risk of cancer and the importance of getting screened in the absence of symptoms.
Wonderful. Are the same trends and disparities present among populations under the age of 50?
Let me answer that in two chunks. So the question about disparities under the age of 50, as it relates to incidence, mortality rates, as well as stage at diagnosis, yes, we still see those same disparities in people under the age of 50, where whites tend to have lower incidence rates than blacks. Blacks are more often diagnosed at a later stage of diagnosis, and there are also differences in mortality rates between those groups. The second part of my answer is about screening. So we don't know yet because the recommendation to start screening at the age of 45 is only about 2 years old. So haven't had enough time to collect sufficient data to see if there are differences in the uptake or sort of up-to-dateness of people under the age of 50 by some of those factors.
Great, thank you. So this individual asks, even though screening rates are improving, why is it that most colorectal cancer diagnosed today is late stage for the most preventable form of cancer?
I think actually the majority of colorectal cancer is diagnosed at a local or regional stage. So there was a slide that I showed where I was looking at black-white differences in stage at diagnosis, where about 20 to 25% of people are diagnosed at a late stage. So really we're seeing an increase or more cancers diagnosed at local and regional stages when it is treatable. I think the reason why we still see a chunk of diagnosis happening at late stages is because people aren't getting screened. And if people were doing that at the right time and the right age, then perhaps we could reduce that proportion of late stage diagnosis even more.
Great, thank you. Has the use of social media helped increase screening rates at all?
I don't have any direct experience with social media and increasing screening, but I know that there are a number of efforts to reach different communities through different platforms like Facebook or Twitter or even text messaging. And so I think, we may see some of that working to increase awareness or remind people, hey, it's March, it's Colorectal Cancer Awareness Month. Have you gotten your screening test, kind of a thing. So I think that's sort of up and coming. I'm not familiar with any studies that have looked at that, but I certainly think healthcare systems and other sort of community-based organizations use social media to engage people and remind them to get screened.
Thank you. Is there any research that you're aware of looking at screening rates in LGBTQ populations?
Yeah, that's a really good question and something I looked into in advance of preparing the slides for today. I will say in cervical cancer screening, we know a lot or a fair amount about differences in LGBTQ populations, where a much lower proportion of the LGBTQ population is up to date with cervical cancer screening. But there really have not been a number of studies conducted in colorectal cancer to look at that same question. So it's something, or at least that I'm not aware of. So it's something I think we definitely need to look at and is an important and growing population that we're trying to understand in the cancer space.
Great, thank you. You mentioned qualified recommendations starting at 45 for the American Cancer Society. Could you briefly describe the modeling studies that led to this decision, since there weren't any trials leading to the recommendation?
Sure, I'll do my best because I'm not a modeler, but I can try to explain in layman's terms. They essentially developed these models to using incidence rates, so a lot of the data that I showed you previously, as well as some of the effectiveness data from trials, and then estimates of how many people adhere or are up to date with screening. So they combined all of those estimates together to sort of predict at what age could we gain the most quality life years or reduce colorectal cancer mortality by the greatest extent. And they do that using a number of combinations of factors like the ones I just mentioned before, and sort of arrive at some conclusions about this is the age, these are the tests. And again, those effectiveness estimates, they do come from clinical trials, but typically those trials are limited to people over the age of 50. So we're somewhat extrapolating the benefit that we observed in those trials and applying them to people who might be younger.
Great, thank you. And on that note, I know the United States Preventive Services Task Force has been mentioned a bit, and that they're currently reviewing initiating screening at age 45. Could you just comment on what the impact of their decision would mean for screening age initiation?
Yeah, I think if they were to change their recommendation to age 45, it would probably have more of an impact in the population than the American Cancer Society guidelines, because most insurances follow the recommendation of the USPSTF. And so they would then be required to cover the cost of the screening test for people between the ages of 45 and 49. So it would have a big impact that way in terms of the younger people accessing tests and being able to get them at minimal charge. And I think, a lot of other organizations tend to believe that the USPSTF is kind of the gold standard of recommendations, so it might have a trickle down effect in that sort of a way too.
Great, thank you. So this question asks, my husband was diagnosed with stage 4 CRC at the age of 49. As I look to advocate and raise awareness in his memory, what screening methods or methodology can make the biggest impact in the younger populations given the current guidelines?
Well, first, let me say I'm so sorry to hear about your husband, and I hope that he's doing well. And I appreciate sort of the advocacy spirit that you've taken on to raise awareness and try to do something about this disease, which again, as we've talked about, is increasing in younger people. There's some talk in the field about if we were to recommend screening sort of universally for people under the age of 50, might we just use a sigmoidoscopy? So you'll remember that's kind of like the mini colonoscopy I described, or even one of the stool-based tests. And that's because the cancers diagnosed in younger people tend to occur in the rectum or the lower part of the colon. So you may not necessarily have to do a total colonoscopy to examine the entire organ, but perhaps a sigmoidoscopy or some kind of stool-based test would be sufficient. Again, we'll continue to see what the organizations and professional recommendations are. The ACS, like we've talked about, already recommends screening at the age of 45 with a number of the different tests that I described. And I think we'll see what other organizations do. But again, some talk that perhaps we could recommend a preference for certain types of screening in that younger population because of where the disease occurs. I hope I answered your question.
That's great, thank you. And as a follow-up, you had a slide showing that FOBT tests were on the decline. Could you comment on why that might be? Is that in response to more colonoscopies being conducted?
I think probably a number of things. Number one, when we think about colorectal cancer screening, I think a lot of us think immediately about colonoscopy. So there isn't as much awareness about FITs and FOBTs, I think, as there are for colonoscopy. Number two, I think a lot of people tend to view colonoscopy as the gold standard, so the best screening test that there is available, because it does examine the entire organ and you can remove those pre-malignant or precancerous lesions. If it is normal, you don't have to come back for 10 years. So I think that's appealing for some people. I can do this one time and I'm good for 10 years versus having to do the same test every year. I will say for the FITs and FOBTs, although it's kind of flat around 10%, those tests do play an important role in some healthcare organizations like the Kaiser Permanente system and other kind of population health management programs where people are primarily screened by FITs and FOBTs because they're mailed to their house each year. So that's been one strategy we've seen that's really helpful in increasing the proportion of people up to date is by being able to mail them directly a FIT or FOBT that they can complete every year.
And following up on that question, are there any differences among the non-invasive tests when it comes to sensitivity or adherence that you're aware of?
There are differences in sensitivity and specificity across the three different test types. So the FOBTs, the FITs, and then the FIT DNAs. I can't quote you the exact statistics other than to say that there are differences. And that's why we see somewhat of a difference in the recommended intervals to complete those tests. So FIT DNA every 3 years versus FIT or FOBT every year. And then what was the second part of your question, Reese?
Let me pull it right back up. Let's see here. Sorry about that. So it was just asking, are there differences among the non-invasive tests when it comes to sensitivity or adherence?
Oh, let me ask the adherence sort of question. We do tend to see that people are good at completing a FIT or FOBT one time, but very, very difficult to get people to do it a second, third, or fourth time, sort of in the absence of those mailed screening programs that I mentioned a few minutes ago. So I think that's another challenge that we have is, if we're going to promote FIT or FOBTs as the way to get screened, really making sure that people who have normal test results come back every single year to complete their test.
Thank you. Do we have any data on the prevalence of adenomas in 40-year-olds?
That's a good question. There are a couple of challenges for deriving a prevalence estimate of the number of adenomas in 40-year-olds. There are a couple of autopsy studies conducted a long time ago that really inform some of those modeling studies I mentioned earlier that are used by guideline screening recommendations. But more recently, you can appreciate that it's a little bit challenging to estimate the prevalence because there are different reasons why people in their 40s versus 50 and older might undergo a colonoscopy. So up until the ACS recommendations, the reason why someone in their 40s might receive a colonoscopy would be for things like family history, so they're at a higher risk, or because they had symptoms, so something like rectal bleeding, constipation, diarrhea, those types of things, or maybe they had inflammatory bowel disease, something like that. Versus people over 50s truly being asymptomatic and undergoing these colonoscopies for reasons of screening. So because of those differences, it's really hard to determine the prevalence or true prevalence of adenomas in 40-year-olds because they might be more likely to be there because of the reasons that they're undergoing colonoscopy. I will say that there was a study conducted in Korea a couple of years ago that tried to get at this exact question. And in this particular study, everyone in their 30s, 40s, and 50s underwent a colonoscopy. It wasn't specific to reasons. And the prevalence of adenomas tends to be, or at least in that study, was about the same as it was in 50-year-olds. So 40s and 50s were similar.
Perfect. Thank you for that. We had another question come in that says, why does the MSTF tier their recommendations?
Yeah, that's a good question. And it's not because some tests are more effective than others. I think they do that to encourage patients to do the tests that they view as sort of easiest to complete. So for example, they choose FOBT as a tier, or FIT as a tier 1 test and not FOBT. Because FIT, there are no dietary restrictions, but FOBT might not be able to take aspirin or eat certain types of foods before you take the test. So the FIT is easier for patients to complete. And in the same vein, they recommend colonoscopy as the tier 1 test over things like sigmoidoscopy or a virtual colonoscopy because they're sort of one and done. So the virtual colonoscopy or the sigmoidoscopy might require a follow-up with a colonoscopy if you find something, but the colonoscopy, you sort of do everything one-stop shopping. So it's more about preferences and not as much about effectiveness is why they break those into the 2 tiers.
And are digital rectal exams recommended at all in the guidelines?
Not to my knowledge, no.
Thank you. Okay, so this question comment says, my daughter was 33 when she was diagnosed with stage 4 colorectal cancer and 36 when she died. She had most of the symptoms, but her physicians continued to diagnose other illnesses because of her age. What can be done to educate practitioners to realize that this disease is affecting our younger generation and send them for screening?
Yeah, thank you for your question. And again, I'm so sorry to hear about the loss of your daughter. That's just so heartbreaking. But you're totally right. You know, a lot of these patients have symptoms of colorectal cancer, like rectal bleeding and some other things that are easily recognized as symptoms in older adults. But for some reason, people are hesitant in younger adults to truly work that up or diagnose that as colorectal cancer. I think we're starting to see the tide change a little bit. You know, there's been a lot of awareness and sort of media and press coverage about the increasing rates of colorectal cancer in younger people. And I think in the absence of having a sort of screening test for some of those younger people, that physicians are doing a better job of working up some of those symptoms. And young people themselves, I think, are doing a better job of reporting those symptoms to be worked up and maybe not ignoring them as much. But we still have a lot of work to do, although I do think we're starting to see a little bit more movement in that area.
Great, and we still have a few questions coming in, so we'll try to get to as many as we can in the next few minutes, knowing that we're getting close to time. What percentage of adenomas become cancerous?
That's also a good question. So the challenge with adenomas is that some may regress or progress rather and go on to cancer, and some may regress and become nothing. We think about 5% of adenomas will ultimately become cancers.
Thank you. And what can we ultimately do to improve incidence and mortality rates amongst minority groups?
I think screening is really key to improving incidence and mortality rates in those groups. I mean, you could see in the data, sort of in the older populations or even in white populations where we know screening uptake is higher, we've seen that translate into big declines in incidence and mortality. And I don't think there's any reason to believe why we can't do the same in minority groups. We talked about earlier sort of some of the barriers to completing tests in those groups. And I think the real challenge is, again, to sort of address some of the logistical barriers, as well as some of the sort of beliefs surrounding the need for screening. And doing that might make a big dent in how people are screened and up to date.
That's great. Thank you so much. And we do still have a few questions coming in, but I think in the interest of time, we can send them to you to follow up with afterwards. Dr. Murphy, I want to thank you so much for spending your Monday, I believe, afternoon in Texas with us discussing screening rates across the board. Like you mentioned, Fight CRC will be diving deeper into understanding screening barriers and opportunities for specific populations coming up in the next few months. So make sure that you are following us on social media and on our website at fightcrc.org, and we'll be sure to post all of those opportunities there and keep our community in the loop. So with that, thank you everyone for joining, and I hope you have a wonderful rest of your week and a good holiday season.
Thanks so much, everyone.